to Professor Turner.
Thank you. All right, today we get to talk about the good stuff. So, let's see. I never pass up the opportunity to remind everyone what nice building I get the opportunity to work in, but we'll move on to the good stuff. Taking care of a patient or a client that is on tube feeding or TPN is definitely not a one-person deal. We need an entire team in order to benefit, in order to have all eyes on a lot of different things, to have better outcomes. The team can communicate, give their opinion. Every person in the team has something to contribute. So a patient on TPN or tube feeding shouldn't be under the care of just one individual. When we talk about starting to assess a patient or starting to look at a patient that's going to need TPN or tube feeding, there's a lot of things that are high that should be low. There's a lot of things that are low that should be high. So there's a lot of different things to start considering. Obviously, this population that's going to need tube feeding or TPN probably has a higher metabolic rate. They're probably burning calories a little bit faster. They probably have increased needs because of temperature. Blood sugars are usually going to be high regardless of what they've had to eat or if they haven't had anything to eat at all. So all of those things need to be considered. Also remember when we talked yesterday about those negative and acute phase proteins, the positive acute phase proteins are the ones that are going to be elevated. So your C-reactive protein and your ferritin, those are going to be higher than normal in this population. Things that are normally higher that are going to decrease are things like their ability to feed. They may not have energy, they may not have strength. It's harder to heal wounds, so they are obviously going to need some more calories for that. They have no energy, no activity level. If they're bedridden, the needs might accidentally go down. So all of this information has to be taken into consideration. And just like we talked about yesterday, the purpose of tube feeding or TPN is to prevent malnutrition. People that come in that can't eat, won't eat, or what have you, can become malnourished very quickly. So always the goal nutritionally is to prevent that from happening. The key to preventing malnutrition then, as far as the RD goes, is to do that first step of the nutrition care process. That was the nutrition assessment. So we're going to look at all of this information, all of those domains that I talked about the day before yesterday. I'm going to look at their medications. I'm going to look at their hydration status. I'm going to look at what the plan of care is. Very important piece of information to know whether I should or shouldn't recommend either the TPN or the tube feeding or what have you. It's important to realize what the medical diagnosis is and if that's connected to any past medical history or information that I need to be aware of. So again, the assessment key, the first step, the assessment part, is pretty important to determine where we go from there. Now, I didn't talk that much Tuesday about part of the nutrition assessment, and that is determining nutrient needs or your energy expenditure. I have to be very cautious here because if I feed too much, I can cause more CO2 production, and that makes it harder for them to breathe. I have to be cognizant of how much fluid they're going to receive. I have to worry about whether or not what I'm going to provide is going to cause high blood sugars. And probably one of the most important things out there is I need to be cognizant of refeeding syndrome. Does anybody know what refeeding syndrome is?
We talked about it. I don't remember.
It's essentially when your cells get bombarded too fast and you try to re-feed them, the shift back to what it's supposed to be is too fast, and then they can present with all kinds of, I think it's
neurological, cardiac, there's a whole slew of complications. You will see a patient that is malnourished come into the hospital and clinicians say, oh, this is a great time, we've got them here, let's feed them, let's beef them up. So they're all about trying to write this gigantic order to get in every calorie that they can. And if their metabolism is down-regulated, if they haven't eaten for 5, 6, 7, 10 days or what have you, or been starving for a long period of time, and you bombard them, I like that word, if you bombard them with all these calories, every single one of those carbons have to go through glycolysis. The system's down-regulated, now you've asked it to work overtime, and there's a whole bunch of consequences. So you really have to know a good background as to everything that's going on. And on the other hand, if I feed too little, I can't heal that wound. I could produce weight loss. They're going to be at a higher risk of infection, and that word, that malnutrition that we've talked about so much already. So finding that balance, finding where I need to be is pretty important. The gold standard of trying to figure out where I want to be or what I need to be feeding is called a metabolic cart. So the gold standard would be a metabolic cart in order to determine their calorie needs. It'll tell me protein needs and everything. Unfortunately, metabolic carts are very expensive. I've never had the opportunity to work in a hospital that had one, so I can't tell you how great they are. I've always had to do things by hand or do some of the equations that we're going to talk about here in just a second. If you have the luxury of working in an institution that has a metabolic cart, you're very fortunate. You might find metabolic carts more in research worlds, but as far as a hospital setting, why they don't spring for the money to do this, I really can't tell you. So if a facility doesn't have a metabolic cart, I still have to determine the number of calories the patient needs, the amount of protein that the patient needs, and also their fluid status. So those are called the macronutrients. Need to figure out how much and how to distribute those calories and that protein throughout the day. I also have to look at the micronutrients. As a result of the nutrition-focused physical exam that we're doing, I might find vitamin deficiencies or mineral deficiencies, so I also need to be prepared to look at those as well. The simplest way to calculate, or the simplest way to figure this out, is called kcals per kilogram. Pretty simple. For every kilogram, you would feed either 20 or 25 kcals per kilogram. The example I gave you there on the bottom is a 165-pound person. That would make them 75 kilograms. If I multiply that by 20 to 25, I'm going to feed this person approximately 1,500 to 1,875 calories. I call this the down and dirty. It's the quickest, it's the simplest. You can do it all day long. Doesn't take a lot of expertise in order to find a starting spot where to begin in order to feed this patient. This is from the resource that I brought here. As simple as we'd like it to be, things get a little bit more complicated. This resource points out a couple different figures based on bariatric surgery or based on unintended weight loss, whether or not they have pressure ulcers. Generally, a patient that's in an ICU, somebody that's sick and not a lot of activity, I'm probably going to work around that 20 calorie per kilogram level. The more I have to deal with, the more I have to combat in ways of injuries or wounds or surgeries or things like that, the higher it's going to go. So you never go over 40 kcals per kilogram, but you could go somewhere between the 20 and the 40 range depending on what the needs are of the patient. Make sense? So that's the quick and easy way. There's something that we've used for a very long period of time though, and it's called predictive equations. Predictive equations are based on the person's age, based on the person's height, based on the gender, and also based on their weight. These are really coming under fire. A whole wealth of research has been done lately on predictive equations. The Harris-Benedict, which was the way I learned in school, is the oldest, but we've now come to find out that it is the least reliable. So if you learned a Harris-Benedict equation, or if you ever knew a Harris-Benedict equation, you're probably never going to see the Harris-Benedict equation used anymore. unless somebody's not kept up with the research and hasn't kept up with the literature. I can tell you, you'll go into facilities and people are gonna say, I did the Harris Benedict, but I don't recommend that you use it. The equation that they recommend today for healthy individuals, healthy walking, living individuals, is the Mifflin. The more complicated it gets, the more you need to know as far as the equation goes. The Penn State formula is used for people that are in the ICU that are on a mechanical ventilator. So if they're having problems breathing, if the machine is breathing for them, then a Penn State equation would be used, and it also includes additional information that you have to plug into your equation for temperature and for the minute ventilation that the machine's using to breathe for them. There's a couple examples of the Penn State formula. You can see from 1998 until now, it's been revised several times. So really the 203B is what they use for most individuals. The 2010, they're using for obese individuals or if you're over 65 years of age, I think. But chances are you're not probably going to have to calculate this, but I do want you to be aware of predictive equations. These predictive equations then we can use to, let's see, not sure if I've got another example here. No, I don't. Go back here. Maybe. Okay. These predictive equations, as I mentioned, there's a ton of research now showing which is the best, which is the worst, which to use in this population, which to use in that population. Always include something called an activity factor. So these equations that you're calculating give you a resting energy expenditure, or what I call a basal. Even while you sleep, your heart is pumping, your lungs are breathing, your liver is producing more new albumin. There's a whole lot going on while you sleep, and it doesn't take any, well, it does take energy, but it doesn't take any effort from you at all. It's doing this the whole time, whether you know it or not. So these calculations, or the predictive equations themselves, give you a resting or a basal energy expenditure. To that, we've always added something called activity factors or injury factors to up the calorie level. Come to find out, none of those activity factors or none of those injury factors are evidence-based. There's no science for them. There's no, you use this in this particular situation, or you use this number in this particular situation. So instead, what I see in the literature today is, instead of saying, take a resting energy expenditure of 1,000 or whatever and multiply it by an activity factor of 1.2, where you're going to get 1,200 calories. Today, instead, what I see is, don't use an activity factor, but take a resting energy expenditure and multiply it by 120%. Is that not the exact same thing? I think it is. So, no. The key here, though, is you have to have a starting point. Whether you multiply by 1.5, whether you multiply by 1.3, whether you multiply by 1.4, it's all based on clinical judgment or clinical expertise. You pick a calorie level and you start there. If it works and the patient's not losing weight, you picked a pretty good number. And that's why we're constantly monitoring as well. If they're continuing to lose weight, guess what? You better up the amount of calories that you give them. So you start and then you monitor. There's nothing that is cast in stone. There is no magic number. There are a lot of things. The disease state needs to be taken into account. How much muscle mass they have needs to be taken into account. Muscle burns more than fat stores do. So you could take a very big person with a large muscular build, put them in a car accident, throw them in the hospital, and they're going to need a ton of calories. Whereas the same person that weighs the same thing that doesn't have that same muscle structure or muscular build isn't going to need as many calories as the other person does. So it's not a science, it's not an exact science. We have to start somewhere and go from there. Sound good? You guys all know how many calories you need? Really? Okay, good. I will say, the number, don't try and do too few. If you think you know how many calories you need, we saw this in Weight Watchers all the time. We used to have a 3-step Weight Watcher program. You could do 1,200, 1,500, or 1,800 calories. You could determine which level you wanted to be on. The people that chose the lower numbers honestly struggled more to lose weight. Any idea why? I hear metabolism.
Slows it down.
It slows it down. Yeah, so you get the body used to living on 1,200 calories, it's going to be just happy on 1,200 calories. You get the body used to living on 1,800 calories, it's going to get used to 1,800 calories. You can honestly slow down the metabolism so bad that you can't lose weight at all. Yo-yo dieting, going back and forth, you can destroy your metabolism where it's never going to burn the number of calories that it used to, and it's almost impossible to rev it back up. So find a good calorie level, find a good exercise program, eat those calories and exercise, and you'll be much better off than if you try to starve off 10 pounds for the reunion or something and have to pay the price later. The Academy Evidence Analysis Library, due to all of the predictive equation research and everything, did come out with this algorithm here as far as evidence-based calories. So we want to use indirect calorimetry if at all possible. So then we would follow indirect calorimetry guidelines and try to feed towards the respiratory quotient. That allows us to determine carbohydrates, fat, protein intake. Or if they're not mechanically ventilated, then we would feed based on the Mifflin for healthy individuals. Or if they are on the mechanical ventilation, then we do use the Penn State formula. So, don't have to memorize that though, but just want you to get the idea that figuring out these needs isn't always easy. And there's a lot of different things to take into consideration. All right, so I figured out how many calories I'm going to eat. Now I've got to figure out how much protein the patient needs. The RDA for healthy individuals, the recommended daily intake is 0.8 grams per kilogram a day. That's not a lot. You guys think you eat 0.8 grams of protein per kilogram a day? You think you eat more than that? Yeah, I bet you do. A 90 kilogram person, that would only be 72 grams of protein. Every ounce of meat has 7 grams. If you've had 10 ounces worth of meat today or 10 ounces worth of protein today, you're done. No more. No more protein for the day. Now, patients in the ICU aren't healthy. The more we need to fight infection, the more we need to heal wounds and everything, the higher this is going to go. So for the critically ill, we can go as high as 1.5 to 2.0 grams per kilogram in order to help them while they're in the hospital setting. So that same 90 kilogram patient all of a sudden needs 135 grams of protein for the day. There's another way, not using the RDA, to calculate how many calories and grams of protein a patient needs, and it's called the calorie to nitrogen ratio. The calorie to nitrogen ratio is used a lot. I'll leave 3 here for the front. And then you can take those inside. The calorie to nitrogen ratio is used to spare protein. I want to supply a lot of calories for energy. I don't want to use my protein for energy. If you provide too few calories, but a lot of protein, the calories are going to be used to be burned for energy. So it's not going to do the purpose that you need that protein, those protein calories or those protein grams to do. Healthy individual can have a calorie to protein ratio of about 300 to 1. Here I have it 200 to 1, and that means then that out of the number of calories that they consume on a daily basis, about 12% of those are going to come from protein. The reason this is used so much in the clinical setting is because the formula companies, the ones that make all the tube feeding product, the tube feeding formulas, this is how they advertise. This is how they sell their formulas to you. Look, this is a 100-to-1 protein formula or calorie to nitrogen ratio formula. So you automatically can kind of know it's got a higher amount of protein and a lower amount of, or a higher amount of protein compared to the number of calories that are used there from the carbohydrates. So do you want to try to calculate a protein to calorie ratio? Calorie to protein ratio. Gotta get in the right order. See if I got an example. How much nitrogen is in 60 grams of protein? You guys had chemistry 101, chemistry 102, I don't know.
Yes.
Huh? How'd you get there? Really? Did I same example on there?
It's 9.6.
So protein's made up of carbon, hydrogen, and of nitrogen. Protein is the only molecule that has nitrogen in there. The amount of nitrogen in a protein molecule is either 16% or you divide it by 6.25. So you got a couple different options that you can do here. 60 grams divided by 6.25 is 9.6 grams of nitrogen. If you do nitrogen balance studies, or if you're looking at negative nitrogen balance or positive nitrogen balance, this is where this type of information comes into play. To find out what your calorie to nitrogen balance is, so that you're allowing protein to do what protein needs to do, you would divide the grams of nitrogen now into the calories to come up with your ratio. So if a person consumes 1,920 kcals, 60 grams of protein, what's the calorie to nitrogen ratio? Should I put that on there too? I don't think so. Divide 1,920 kcals by 9.6 grams of nitrogen. What's your answer?
201.
200 to 1. Yeah. So this is a higher calorie level to the amount of the protein, so this person's a little bit healthier. In an ICU, it's not uncommon to need 100 to 1 just for them to have the proper amount of protein that they need so that the protein doesn't get metabolized for energy. Make sense?
So we're dividing the grams per nitrogen, or?
The grams of protein per nitrogen. Right. You can divide it by 6.25.
That
Or you
equals
can-
307 though, not 200.
Yeah, I think,
You
because I wrote it down.
9.6.
Yeah, you divide 1,920 by 9.6. Because that's how much nitrogen's in 60 grams.
Okay, okay.
I can complicate it because I can say, or you can take the 60 grams of nitrogen and multiply by 16%. You're going to come out with 9.6. It's the same either way. Are we good? So part of every protein molecule has nitrogen in there that you're going to need for growing, healing, and all that good stuff. Cool. In terms of fluid for the patient then, several different ways that you can go about calculating it. If you want a down and dirty method, the quickest, easiest method is for every calorie you're going to have them consume, 1 ml of H2O. And that's 1 ml of free H2O. It's 1 for 1. That's the simplest. In pediatrics, they've got some different formulas that they use. You might find other formulas, method number 3, where you start with 100 mils for the first 100 gram or kilograms. There's other formulas that are out there, but I can almost promise you everyone's going to do 1 for 1. If I'm going to feed them 1,920 calories, I need at least 1.9 liters of fluid or 1,920 mils of H2O. So that's the simplest. Good? So So our macronutrients, the things that we need to consider or keep in mind is that if we feed too many carbohydrates, it's possible that we can increase blood sugars. It's also possible that we can increase CO2 production. Every one of those carbons have to go through glycolysis. Every piece of the metabolism, or protein, fat, or carbohydrate, either one produces CO2 as a waste product. So carbohydrate, I'm going to produce much more CO2 that I have to blow off. And if a person has a lung disease, I probably don't want to do that. So I'm really going to be looking at the amount of carbohydrate that I'm going to have a person consume. If I feed somebody too much fats or too much lipid, the omega-6s are pro-inflammatory. You'll be surprised to know that the lipids that they have in TPN are pro-inflammatory. But we have a new product on the market now. Where's it been? I mean, it's only been out on the market for a year or so. So can't overfeed lipids either. You may need higher calories. You may want to use a lot of them, but you have to be careful about the makeup of them as well. And then if I feed too much protein, I have to start worried about renal clearance. So too much protein can complicate things when it comes to the kidneys. So there's a lot to think of, a lot of things to consider as you go about trying to take care of people that's either going to be too fat or on TPN. Just a couple of the micronutrient things that you need to worry about. You're probably going to be worried about iron. You're probably going to need some zinc. You're going to need selenium if they're on TPN. So all of these things are also things that we need to consider. You're definitely going to need thiamine if you're infusing calories and they haven't eaten in a while. So a lot of things to think about. Remember, if you're looking at feeding these people that are in the hospital at the DRI level, you're making a mistake. The DRIs are for healthy people. So you may want to give them 75 milligrams of vitamin C because that's what the DRIs say, but that might not even touch the surface if it's a real complicated case. So we're probably going to override most of those DRIs most of the time. All right, once we know how many calories we want to feed the person, then we have to decide, can they eat orally? Can they not eat orally? Or is there a complication if they do eat orally? So now we've got another algorithm we have to go through. A little decision tree. I also put the website, this is actually a 19 or 20 page document. I did put the website there at the bottom of that for you, but I think it's a good one-pager for you to see things that you really need to consider. If at all possible, and I'm sure my students get pretty frustrated or get really, 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 really tired of me saying food first. If they can eat, if the GI tract is working, I'm going to offer them food. So that's the very first choice. If they can't eat, maybe they're too sleepy to eat, maybe they're too drugged to eat, but the GI tract is still working, I'm going to go with some type of an intro plan. If the GI tract, so the first place you look is, is the GI tract functioning? And if it's not, you're going to go straight to TPN. If the GI tract is working, then you're going down the right side of that paper there based on a couple different conditions. So we try to feed them food first if they're fairly alert. We might need some real nutrient-dense foods because they might not be able to eat a lot. We might have to come up with some supplements, and we just had a big conversation at lunch today over eggnog. My students seem to think that the only thing they remember from M&T 1 is how much Peggy likes eggnog. But the reason is because it makes a great supplement. The little sick people really like it. They'll drink it. It's Christmas time. So instead of trying to go give them a can of Ensure, I'll ask them if they'd like to have a little bit of eggnog. So you can remember me as eggnog for sure. If they can't eat orally, then my next choice is going to be enteral nutrition. Enteral nutrition is feeding through the GI tract via tube, via catheter, or a stoma, delivering nutrients distal to the oral cavity. Possibly they've had a stroke and they're just not safe They've done a modified barium swallow, and the muscles are not strong enough to facilitate that swallow. So the gut still works. I need to try and come up with a plan to feed them enterally. It's contraindicated for people that have any type of obstructions, any type of fistulas, any type of ileuses. I'd probably go straight to doing some TPN. So next, if you do make the decision that you're going to feed them enterally, you've got to decide where to place that tube. The other thing my students probably get tired of hearing is you have to know where that tube lands. And by that I mean, when you drop a feeding tube, do you stop in the stomach? Or does the tube go through the pyloric sphincter, and does it go into the small intestines? Or does that tube need to go down into the jejunum? Where does that tube land? Because that's going to make a huge difference as to types of formulas that you're going to use, how much you can use, and a lot of other things that you need to consider. So it's not good enough to know that you can see they've got a tube in their nose, but you need to know where the tube lands. So I brought a tube here. You can kind of get an idea of that hanging out of somebody's nose, going down into the GI tract. And the way you can tell sometimes where it lands is there's numbers on here. So this part would be hanging out. They kind of put a tape there at the end to see how much of it is left. And this is what you call the tip here. That's where the end of the formula comes out and goes into the GI tract. Somewhere, but you have to know where. You can place tubes in the nose. Post-pyloric is past that pyloric sphincter, so you've gone through the stomach into the duodenum. Ostomies are more permanently placed type feeding situations. This type of tube, I'd recommend if you need someone to be fed enterally for up to 6 weeks. If you know you're gonna need something longer than 6 weeks, I'm probably gonna recommend that PEG. And that PEG goes straight into the stomach. You don't have to use the nose now, but the tube feeding formula can go in through the PEG in the stomach via a syringe. A lot of things to also consider if you're going to place that. A lot of things can go wrong. One is aspiration. Do you guys know what aspiration is? Aspiration pneumonia? Okay, good. If this tube going in their nose, where we're going to put tube feeding formula in, is the only intake that they're going to consume, they've got no IV fluids. They're pretty stable, they've got tube feeding formula, and they do not receive any additional H2O, you're going to have a patient with dehydration in a very short period of time. There's not enough water in that tube feeding formula. It's not a 1-to-1 ratio. So if you aren't providing additional fluid when you're tube feeding a patient, either IV fluids or through a syringe, you're going to wind up with dehydration. Tubes can clog. We'll talk a little bit about that in a minute. They can also migrate. So you have to be sure it's marked. You need to make sure that it's not coming out on one end or that it's migrating somewhere differently. And probably the biggest problem, if I had to say the problem that is the worst about complications, is they get turned off. They get turned off to take a bath, they get turned off to go to physical therapy, they get turned off for a lot of reasons. So here's the actual placements of where tubes can be placed, either in the stomach, in the duodenum, or in the small intestines. The ostomies on the other side are permanently placed feeding arrangements. Once you know where the tube lands now, you have to come up with a regime where you're going to either feed them for 24 hours a day. You can feed them bolus 3 times a week, or 3 times a week, what am I saying? 3 times a day, or you can feed them nocturnally. So what did you guys have for lunch today? Huh? Subway? Okay. Enjoyed your meal? Ready for a little learning? Liver's happy, it's doing a little metabolizing and a little synthesizing. The liver's got a break now. If you feed somebody for 24 hours a day, it never gets a rest. It never has downtime. It never has a chance to do the many things that it needs to do. Continuous is probably what you're gonna see most often, I can almost guarantee you, in the hospital setting. It's easiest for nursing. They set the pump up, turn it on, and they don't have to worry about it except to replace the bag. Nocturnal tube feeding is fed from, like say, 6 o'clock in the evening until 6 o'clock in the morning. So nocturnal means during the night. I had a phone call one time after I got home from work one day, and I got a page, and the nurse says, "Peggy, I have an order for nocturnal tube feeding, and I don't have any formula by that name." I went, "And you won't either." Nocturnal means during the evening. So you might have a situation where the patient can eat to preference or to choice or at liberty to eat what they can during the day. There's no pressure that they have to consume this or that. But then to make sure they get adequate intake all night long, there's additional input or additional calories for them. Intermittent is to gravity. I don't see that quite as much, but probably going to see 24 hours most often. I definitely prefer bolus. Bolus 3 times a day. It's like you and I eat all along. Our liver gets a rest. Makes me happy. And then you've got to pick the correct formula. You've got to pick the proper equipment and get things all set up. Nursing is usually in charge of the pump. They're in charge with hanging the tube feeding formula. The picture that I have here is tube ready to hang formula and also a can of formula. Previously, what we would do when we write an order, if the ready to hang can come in a full liter or it can come in a 1.5 liters. The benefit there is you don't have to open up 4 cans, or you don't have to open up 6 cans and pour in the bag. So there's less contamination, there's less hands involved. The closed system is what I would hope that you're going to see most often in the hospital setting. So there's the closed. After a tube has been placed, when a feeding tube is dropped, who do you think should drop the feeding tube? Huh? The provider, the surgeon, nurses, PAs, or dietitians. The dietitians, there's a piece of equipment is called a CORTRAK Med System. Here's a picture of one. CORTRAK Med System is, as much as Peggy likes technology, I call it my tube feeding toy. It is a device that has I call it a GPS at the end of the tube. And it literally, this device here can follow you as you're dropping a tube down an individual. You can see whether or not you're making a C in through the circular area of the stomach. So this is how I recommend tubes be dropped. I've dropped feeding tubes this way, and I would like to see much more. Whether it's me as a dietitian, whether it's you as a PA, the reason I want to see people using this technology is, number one, it gets done much faster. Now the situation is a dietitian may have to recommend the calories, the protein, the tube feeding formula, what have you. The doctor has to come back, he's got to write an order, he probably won't be back till tomorrow, so it's going to be tomorrow before he physically writes an order. Then nursing has to get the order, they've got to go drop the feeding tube. I mean, you lose so much time when you depend on so many individuals to take ownership of this. So if the dietitian is consulted, then the dietitian knows what tube feeding formula should be able to drop the tube. You should be able to get the process started within an hour. That's all it should take in order to get the process started. With the technology, you know where that tube is. You know if it's going too far into one of the lungs, you can pull it back up and start going back down again. You know when you've passed the pyloric because you can see it on a physical screen. So I'm excited about more facilities purchasing this. We used to have a dietitian in Bartlesville that dropped feeding tubes using the CORTRAK Med System. didn't get all the work she wanted, if that's a way of saying it. She didn't get to drop tubes as much as she wanted to, so she went down to Baylor. Baylor in Texas, they drop feeding tubes all the time. So there's little pockets throughout the country where, I mean, that's practically all dietitians do is drop feeding tubes. It's not a hard process like you may think it would be. You take, if you don't use that type of equipment, then what has to be done before a person can still be fed is you have to have that x-ray. That x-ray has to confirm placement. So with the technology, you can save that cost right there. The other thing that has to happen after a person has a feeding tube is that their head has to be elevated 30 degrees. Otherwise, tube feeding formula going into somebody's stomach that is laying flat is not a good situation to have. Make sense? So there's dates and times and everything that goes on these closed systems. You're going to have to monitor tolerance, and you're going to have to monitor something called gastric residuals. Anybody know what gastric residuals are?
Reflux.
Have any experience with any of this yet, or not so much? Nothing yet? The amount, you set the tube feeding pump up to infuse either 75 mils an hour, 100 mils an hour, 85 mils an hour. If you set a tube feeding pump up on 60 cc's an hour, 60 mils an hour, this is how much tube feeding formula they're going to get in the first hour. Does that look like a lot? This is 1/4 of a cup. It is 60 cc's. There are 240 cc's in a cup. Cc's and mils are the exact same thing. So does that look like a lot? No. If you wrote a tube feeding order for 120 mils an hour, wow, it's bigger. You can probably drink that with one gulp in some of your water bottles. Does that look like a lot? It's not. It's really not. When we check residuals, we're checking residuals to see if what we've infused is still sitting in the gut or not. Whenever tube feeding order is written, the order also is usually written for check gastric residuals every 4 hours, every 6 hours, every something. And those are recorded. Now, just stay with me for a minute. If a person is in the hospital, they're on an oral diet, I take the tray in, I put it down in front of them, I don't say, wait a minute, I need to check your gastric residuals before you can eat. Does that make any sense? No. But we've gotten into this habit of checking gastric residuals for people that are on tube feeding. If a gastric residual is high, nurses panic. They stop the tube feeding. Oh my God, you're going to aspirate. Oh my gosh, this is, I can't put any more in there. How much secretions do you think you swallow on a daily basis? Huh?
Liters.
Liters and liters and liters of gastric secretions you swallow every single day. Historically, what happened if a tube feeding order was written for 100 cc's an hour, nurses were told that if it's 2 times that rate, you've got to stop everything. So if the order is 100 mils an hour, if they checked residuals, they're literally pulling out stomach contents, hydrochloric acid and all. They're literally pulling out residuals, whether it's tube feeding, hydrochloric acid, secretions or whatever, and measuring that. If it was more than 2 times the rate, everything got stopped. If it was 60 cc's an hour and they got 120, the world came to standstill. Everything had to stop. The bad part is they never got started again. They don't turn the pump back on. So, oh, they're not tolerating it, we've got to stop it, they're not tolerating it. They might get aspiration, where that's not the case at all. And once they pull out those gastric contents, they measure them, they need to infuse them back. They need to infuse back for pH, they need to infuse that hydrochloric acid. They don't get the privilege of going and flushing it down the toilet or anything like that. That's part of the GI tract and part of the digesting process. New protocols have come out. They're slow to be adopted, but the Aspen guidelines, the American Society for Peripheral and Enteral Nutrition says you do not hold a tube feeding formula or a tube feeding pump unless your gastric residuals exceed 500 mils an hour. So you do not stop that pump if you get 100, if you get 200, 400, or 50, you don't have to stop the pump. So not everybody is there. There are still those that are in panic mode. There are still those that it's going to be a while to catch on, but we'll get there. If you do seem to be getting residuals that are higher than normal or more than you're comfortable with, there's some things that you can do, there's troubleshooting that you can do. You can lower the infusion rate a little bit if that makes you feel more comfortable. You might want to use a higher caloric density of a formula. So instead of using a formula that has 1 mil per 1 calorie per mil, you use a formula that has 1.5 calories per mil, so you can have more calories in a lesser volume. That way you're not infusing as much. And several other things you can do, like prokinetics to try and keep the system moving, instead of stopping the tube feeding. So I promise you're probably going to see a lot of people still holding tube feedings or stopping them. The more we educate, the more we get people on board, the more we show them what the guidelines are now, we hope that changes. Another thing that you can do if gastric residuals are higher than you're comfortable with is look at the amount of narcotics that they're on. You can assess the fat content. Fat produces satiety. The higher fat formulas may hang around a little bit longer. Or the worst case scenarios, you might have to have a KUB or some type of GI follow-through study to see how the GI is emptying. Another problem with tube feeding is that tube feeding formula is notorious for causing diarrhea. True or false?
True.
All those who want to say true? All those who want to say false? Yeah, 50% of you are right, 50% of you are wrong. It's not the tube feeding formula. If you look at these individuals, now, most of the time what happens, somebody comes in, they've got to be assessed, they've got to get the time to get the tube feeding down, got to get time, or the tube dropped, get things started, get the patient orders written, get those medications started, get that tube feeding started, and everything starts at the exact same time. You have to determine what type of diarrhea there is, first of all. There is a type of diarrhea that will stop if you stop the whatever it is. There's a type of diarrhea that won't stop regardless of what you stop. So secretory diarrhea is caused by bacteria. It's not going to stop until you get rid of that bacteria. So I don't care if you stop the tube feeding, you're still going to be cleaning up poop because the tube feeding formula is not the cause. Osmotic diarrhea, on the other hand, is caused by an influx of fluid into the GI tract. The minute you stop what's ever going into the GI tract, then the diarrhea will stop. So just because a patient has diarrhea, I can retire today if I get to count all the consults that I have for tube feeding formula causing diarrhea. I wouldn't have to be working any longer. It's not the cause. C. diff, another possibility for the diarrhea, could be a problem. Antibiotics cause diarrhea. Has anybody been on antibiotics for longer than they care to and paid the price? What do antibiotics do?
Kill bacteria.
You kill bacteria, where's it gotta go? Gotta come out somewhere. So antibiotics are also notorious for causing diarrhea. So look at a chart. They get 3 or 4 antibiotics ordered one time. They get a tube feeding ordered at one time. They get narcotics ordered at one time. And all of a sudden, now they have massive diarrhea. Other things that you can do is check for the C. diff, check for medications. You might try a tube feeding formula that has more fiber that can assist with diarrhea. You might consider probiotics as something that you can add possibly. Be sure to monitor for your fluid and electrolytes. Diarrhea can cause potassium problems, fluid problems, and if you have to, order a GI consult. Don't stop the tube feeding. Just to make my point, I want to point out that an osmotic diarrhea is very possible for somebody that's taking Lasix liquid. So tube feeding formulas are, this is the osmolality of these particular items up here. Tube feeding formulas are about 250 to 875 serum osmolality, or osmoles per liter. Osmoles per liter. What's your normal serum osmolality sitting here right now?
Up to 350.
Louder.
275 to 350-ish.
275 to 350-ish? 350? Serum osmolality, well, and then you can measure osmolalities in urine and, I'm talking about serum osmolality. It should be about 280 to don't go much more than 300. If you get much higher than that, then you're looking at somebody that has dehydration. Serum osmolality is how you determine dehydration. It can be run in a lab or it can be calculated either way. But my point that I'm trying to make is tube feeding formula 250, 3, 350, 4, that's not bad. Whereas some liquid medications, look how 3,938, what does that do to diarrhea? So it's not always the tube feeding that you need to consider. There's a lot of other factors to include. The other thing that you have to do, I think I can finish this and maybe we'll be ready for a break, is tube feeding tubes can become clogged. The tube feeding formula going in, a lot of times the tube feeding formula is stopped so that they can crush medications and put them into the tube. Remember, if a person's not safe to swallow, if they're asleep, they may not be taking meds orally at all. So they're either going to have to be liquid medications or they're going to have to be crushed and put in a tube. So certain medications, not all, can be crushed. They are then inserted into the tube, and a little bit of water before, a little bit of water after, and they get into the GI tract where they're supposed to go. Too many times, there's not a flush before, there's not a flush after, and a tube will become clogged. It has to be unclogged, or you have to drop another feeding tube. Warm water is the best prescription for a tube that is clogged. 50 mils of warm water, you should be able to gently insert and unclog that tube. Good nursing practices where they're flushing before the meds are injected and after the meds have been injected, the better off you're going to have with not having tubes that are clogged to start with. Warm water is not used all the time. Any idea what they use? Where have you worked?
My dad has a pipe tube.
Your dad has a pep tube. Well,
We don't use Coca-Cola.
okay, good, all right. I didn't know how, whether to jump on you or
Not
cut you a break. Good. Yeah, you do not use Coca-Cola to unclog a tube. I can tell you they do it all the time. What the carbonic acid, the phosphoric acid, the contents of the Coca-Cola will break down the tube. So you're going to be now looking at replacing the tube because it's really going to become ineffective if you do it. They think the carbonation is going to unplug it. That's why they use it. Please never write an order to use Coke. Never let anybody around you use Coke to unclog a feeding tube. Warm water is the best thing you can do. If you can't get it unclogged with warm water, you can use pancreatic enzymes. You can use bicarb. There's a couple other things that you can use to unclog a feeding tube and save the safety of the tube itself and not having it break down. Make sense? All right, last thing I'll say before we take a break. Whatever you do with the tube feeding, whatever, the order that you write, the tube that you drop, the formula that you're gonna have somebody hang for you or what have you, own that tube feeding. This article written by Stephen McClave, who used to be president of ASPN, the American Society for Parental and Enteral Nutrition, did a survey and realizes that 51.6% of goal calories ever actually get in. That's bad. That's bad. So that means if we really want someone to have 1,800 calories, they're probably getting 900 calories on a daily basis. Not good. And we wonder why we have malnutrition. And we wonder why we can't prevent them from losing weight. So nursing should be documenting how much is infused on a schedule or on a shift basis. One thing they've done to try and combat this is now you might find orders for volume-based tube feeding. Volume-based tube feeding means that order is written 1,800 mils of Jody formula on a daily basis. I don't care if you do that on the AM shift, I don't care if you do that on the PM shift, I don't care what shift you do it on. At the end of the day, 1,800 mils needs to be documented. If you did that on an hourly basis, great. If one shift took a couple hours off for dinner and didn't do anything at all, somebody's got to come along and make it up. So a whole school is out there now doing new research and trying to determine the outcomes of a volume-based tube feeding regime so that 75 mils an hour doesn't work, it gets turned off too often. So you might see that while you're out there practicing. All right, let's stop there. Good place to stop. Let's take a break.